Okay, we're going to talk about the uplifting topic of ALTE and SIDS. It starts on page 113. Both very important topics, ALTE and SIDS, turns out not related to one another, so we'll get into that as well. ALTE stands for apparent life-threatening event. Hang on a sec, I have a little tiny head and this headset keeps falling off. So let me see. Okay, apparent life-threatening event. This is something that happens in children, usually young children, and it's a combination of apnea, a change in color or muscle tone, and an episode of choking or gagging in an infant, okay, usually under the age of 3 months. 2 to 3 months of age is when ALTEs tend to happen. The vast majority. And when they look at data on children that are brought to the emergency setting, it accounts for 1/2 to just under 1% of cases that we see in the emergency department. The causes of this are very widely ranging, and we'll talk about that in a second. But there's certain things that we need to gather information-wise on these cases of apparent life-threatening events, ALTE events, that we have to ask either paramedics and or the caretakers what occurred at home. So for instance, we need to do a really good H&P, and we'll talk about that in some detail in a minute. But we also need to ask about what was involved with the ALTE event, with this apparent life-threatening event in this brand new little cute little baby. And you have to ask about color change. Did they turn blue? Did they turn pink? Did their color not change at all? Did they get pale? Did they lose muscle tone? Did they get floppy with this episode? Did they choke? Did they stop breathing during this episode? Did they have any evidence of seizure activity? And did you need to do anything to get them back? Or did they come back on their own? Was it just this 10 to 15 seconds of my child turned totally blue, got all floppy, didn't seem to be breathing, and then I didn't do anything, and then he was normal again? That's an apparent life-threatening event. And the things you need to ask, because these are the infants that are at risk, are infants that had complicated deliveries or complicated pregnancies. And in particular, and asterisk this, is premature babies. Preemie babies are at a significantly higher risk, proportionately, of having an ALTE event. Also, babies that have symptoms of GERD. Okay, babies that have GERD, these tend to be the colicky kids, the crying kids, symptoms of GERD, and kids that may have had a positive neonatal metabolic screen. Those are the kids that are at the risk for having an ALTE event. When the other thing to look for when you're doing your history and physical as far as an ALTE kid is you're going to focus on, you're going to ask about this sort of prematurity and all that stuff, but you're going to focus on any evidence of abuse. It turns out that an ALTE event where it, quote, took some resuscitation at home, I needed to do mouth-to-mouth, I needed to jiggle my baby, or ALTE events where the child still isn't normal when you see them. Yes, they had this ALTE event, and there's still something off when you see them. The risk of child abuse skyrockets. When they look at those children, it turns out that 1/3 of these ALTE events turn out to be related to child abuse. So one of the things, whenever there's some event, unexpected event that happens with a child, we always need to kind of just think about child abuse. It's part of what we're mandated to do legally and ethically, is to protect the children. So first and foremost. So just know that child abuse in severe ALTE cases, the kid that needed to be resuscitated, or the kid that basically still doesn't look right when you see them, just throw child abuse in there as something to be worried about. And child abuse includes not just I shook my baby because they were crying and I have shaken baby syndrome. It also includes Munchausen's by proxy. So this is something where the parent gets by making their child sick or saying that their child is sick or bringing their child in for health care, that's a Munchausen's by proxy, which is also in the thing that can be sort of with this ALTE event. Now your workup of a kid with ALTE can include a whole bunch of things, and rather than go through the list of things, let's go through what they might have. Okay, what the child with an ALTE might have. So if you go into kind of the next section, what are the diagnoses? If a kid comes in with ALTE, what do they end up getting diagnosed with down the line when their workup happens? What do they end up getting diagnosed with? A couple of things. There's a paper in there that's quoted that's not yet in the database. It's coming down the pike, but this is actually by one of my colleagues, whose office is just 2 doors down from mine, who did a study looking at almost 1,000 ALTE kids and gathered a huge database of information on these children to try to figure out what was it they had, what happened to these kids, what were the issues. And she found that for this 1,000 children with ALTEs, the median age was 30 days. So ALTE events are things that happen to young infants. You don't really get ALTE at 9 months or a year. Now you start to get into something else is going on here. If this child's having these apparent life-threatening events, something's funny in that regard. The true ALTE cases tend to be young children. And the things that turn out to pan out that they have, the majority have GERD. So about a third, when they get a final diagnosis, have GERD as their diagnosis. So that's first and foremost. About 10% have a URI. So they have some sort of upper respiratory infection that's causing their problem, 10 to 13% or so. About 10 to 13% or so have seizures as their ALTE event. It turns out to be seizures that are the problem. So you have about 50 to 60% of the diagnoses falling into those three big categories: GERD, seizures, URIs. Okay, so that's going to help guide us in our workups, because those are the things we're looking for. Less commonly, things like UTIs, very uncommon actually, to be serious bacterial illness. And that's different than it was 20 years ago. You know, the kind of nerds in our high school chemistry classes who decided to go into work at the NIH and develop vaccines saved way more lives than you and I ever will. And after the Hib vaccine and Prevnar, we're seeing so many fewer bacterial infections that it turns out that serious bacterial infection, as far as an ALTE cause, is extraordinarily rare. Okay, it's just very, very uncommon. It's less than 1%. And the one other category that we worry a lot about, because it's potentially lethal, is cardiac. Is there some cardiac cause for this infant to have had an ALTE event? And that can be either dysrhythmic or some sort of congenital heart deformity that's causing the trouble. I'll tell you the clues to that on you clinically. If you want to get history, that'll help clue you into that. These are children who feed poorly. Okay, the increased stress of feeding usually causes trouble. They tend to feed poorly, and they get diaphoretic when they feed, or get unexplained episodes of diaphoresis. Think about it. Babies, infants, don't sweat. They just don't sweat. And a baby, a newborn, less than 3 months of age, actually a child, a little kid that's sweating, that's scary. And that's usually a sign of something that's causing a sympathetic stressor to the system, be it a SVT, be it a congenital heart deformity. So those are two kind of clinical clues that will clue you in to feeding difficulties and diaphoresis. Those kids have trouble, and that will clue you into maybe a cardiac cause being the problem. And then one other little weirdo thing that can happen, and I think I've seen probably half a dozen cases in my 25 years of practice of this, is infant botulism. And this is something that those children will not look normal when you see them. They'll have an ALTE event at home, and they have a decreased tone. Think about it, little babies, they're so much fun, right? They're these little warm, stiff little bundles of fat and cute, and they're just the cutest things, but they are not floppy. Babies are not floppy. If you have a child who's kind of just blobbing out there on the gurney and they don't have those nice little stiff arms, and that is a child that you have to worry about the possibility of infant botulism. And the only reason it's thrown out there is if you don't think about it and you don't ask about things like honey, which is implicated probably more often than it actually really happens, but honey is a potential source of the botulism toxin, the spore in botulism. You have to ask about that, because if you miss botulism, and it's diagnosed later, several days later, they're likely, there's an antitoxin you can give to these kids if they have infant botulism, that if you wait too long, their reversal is suboptimal. Okay, you can take care of these kids just fine if you get them in time. So it's just something to kind of throw in there. I usually ask about, what are you feeding your children? Is there any honey around the house? The reality is the spores are everywhere, but they concentrate in honey. So that's why we worry about that. So if we know that the differential, it's 3 months of age or younger, they have a change in color, they have apneic episode, they get floppy, change in tone. And I know that GERD, URIs, and seizures are the top 3 categories. That's going to catch most of them. What should my workup be? Well, it turns out there's abstract number 6, looks at all the possible testing that you could do in a child who has ALTE. All the kinds of things you could do. And it goes to anything from screening for GERD, cultures including urine and UAs, imaging the brain. Could this be child abuse? Could this be a child who has shaken baby syndrome? Doing a chest x-ray. Is this a URI or pneumonia kind of thing? Doing a pneumogram, watching the child breathe overnight. White cell count, any evidence of infection, that sort of thing. All those things can be done. Each individual test has a relatively low yield. And it doesn't necessarily mean that every kid has to have every test. So I went to one of my colleagues, because there's not a lot of great summary data out there for you to say, okay, I recognize this is an ALTE episode. I want to know what best to do about this as far as working them up. And I went to one of my colleagues who is really, truly a pediatric EM goddess. She's remarkable. And she's done a lot of sort of looking into the literature and was part of that study that did the ALTE sort of database. And her recommendations are the following as far as working up a kid who's had an ALTE episode, with the caveat of the yields are low, but it's a framework to approach these children. So if the child is afebrile and looks well now, didn't need resuscitation on any level, just had this short episode at home, looks well. What she recommends is a CBC, a Chem10, a UA, a chest x-ray, and an EKG. If there was any concern that it might have been a seizure, adding a lactate. Okay, so that's her recommendation in that group. If the child is febrile, she said just shift gears and move over into working them up based on their age. ALTE episode in a 3-week-old is going to be a different workup than an ALTE episode in a 10-week-old because the cutoff is 4 to 8 weeks. Most people now have 4 to do the full sepsis workup. 4 weeks to 12 weeks, it's sort of a more subjective based on how the child looks. But overall, base the workup on age. Consider also checking for pertussis and RSV because they're still at risk for those. Now, if the child looks sick, the child is not looking normal to you at all, or they needed extensive resuscitation for real. Paramedics got there and said, oh, no. We had to ventilate the child short term. This was a sick kid. That's a full workup, full septic workup, considering a head CT, worrying mainly about shaken baby, lactate level, ammonia, RSV, pertussis. Okay, that's the recommendation. And again, what you're getting is, and this is your ED workup. Okay, this is just what you do in the emergency department. And I think that's pretty reasonable as far as getting what you need to know if there's an emergent thing going on you need to address right now. Once you've done your workup, what do you do with these kids? So now you have to decide what to do. Most of the literature says admit all ALTE. It's kind of an interesting concept, I think partly because we just have trouble assessing these little kids. And there is a small but significant proportion of these kids who may have something serious that needs to be worked up. That being said, it's kind of overkill to admit them all, depending on what their follow-up can be. What we'd like to do is know which group of kids is at the lowest risk of having something bad happen. And there is actually a couple of things that have panned out as far as likelihood of badness in a child. So the following clinical manifestations say this is a kid who's at higher risk of something bad. If the child is premature, if the child has an abnormal physical exam when you examine them, if the child had cyanosis at home as part of their ALTE, or cyanosis as part of their ALTE episode, if the child did not have a choking episode, and if the child doesn't have any signs of a URI, that child is in the highest risk group of this being something bad. And what they're doing is so think about it. If the child didn't have a choking spell, it's less likely to be GERD. Remember, GERD is a third of them. And if the child doesn't have URI symptoms, it's not going to be that 10% that has URI. So now I'm getting into the smaller group that's the higher risk of the bad stuff. Okay, I'm actually paring it down to the higher risk of the bad stuff. Theoretically, and this has not been validated, theoretically, if a child fits all those 5 things, they're not premature, they didn't turn blue, their exam is totally normal, they basically had a little bit of a choking or a little bit of a URI symptom kind of thing, that child is probably okay to go home. It hasn't been validated. So if you really want to know what to do with these kids, the safest practice is admit them all. If you don't admit them all and they don't hit any of those scary criteria, I would give the pediatrician a call and say, here's a scoop. What would you like me to do with your child? The workup so far is negative. Here's the history. Here's what happened. Do you prefer your children all get admitted, or can you see this baby tomorrow? It's probably okay to send those kids home, but it is not your usual practice. So that's ALTE as it stands today. Any questions about ALTE? Because we have a little segue into SIDS. SIDS is sudden infant death syndrome. And what ALTE is not is a harbinger of a potential SIDS. It turns out that ALTE and SIDS are probably entirely unrelated to one another. We used to, I keep old textbooks. I love old medical books, love them. I go find old historical ones, and I love the textbooks that I have had through my career, and I've kept them all. I don't toss them. Because one of the things that's fascinating to me is to go back to 25 years ago when I started this practice and go to Rosen's or go to Harwood Nuss or all these big fancy books and see what we thought was the cool thing to do then. Because there is nothing more humbling and there's nothing better to get you off your high horse than to realize that we don't know what in the hell we're doing. And we try to do the best we can at any point in time based on what we know. So ALTE, back in those textbooks, was felt to be a concern for a child to go on to SIDS, to go on to become a sudden infant death kid, which is why we admitted all of them back then. We've now done research that says, you know what? It's unrelated. So they've looked at ALTE kids, and the risk of actually an ALTE kid going on to become a true SIDS death is vanishingly small, to the point where it's probably the background rate of SIDS. Having said nothing to do, it's just two Venn diagrams that overlap that have there's no causative relationship there. So ALTE doesn't mean the child's going to go home and be found dead in the crib, crib death. But what is SIDS? It's very important to know what defines SIDS, because our job is to know what isn't SIDS, and particularly what might be child abuse. So a couple things about SIDS. By definition, it is the unexpected death with no apparent cause after full investigation, including autopsy, in a child under the age of 1 year. So if it's a 15-month-old, that's not SIDS. Okay, something else happened to that child. That's not SIDS. And 90% of SIDS is 6 months of age or less. So even a 9-month-old, technically it can still be SIDS, but you start to raise an eyebrow. We don't know why kids do this. We don't know why a totally normal, incredibly adorable 3-month-old who gets put to bed for their nap, an hour later is found dead and blue in bed. We don't know. There are theories, though, that it's related to a child's central nervous system response to hypercapnia. There have been some studies that have actually looked at this, and the initial studies that led to a huge change in what we do with babies was done where they took babies prone, and they basically measured end-tidal capnography in these children and watched what happened to their respiratory cycles. And what they found is some of these kids became hypercapnic and then stopped breathing from being prone. What that led to was a program called Back to Sleep. And any of you who have newborns or been around your grandkids or your children or friends that have kids, there's a program now that basically you are supposed to put your babies to sleep supine. Okay, face up, back down, put them on their back to sleep. Just the initiation of that program dropped SIDS deaths in the United States by 60%. 60%. Dramatic, absolutely dramatic. It's pretty clear that there's something about SIDS kids that has to do with their central nervous system's response to either their breathing pattern, whatever they're breathing around them. And it can be smoke, it can be what's in the crib with them, and it could be position. So that, and they had a similar program in the UK had the exact same result. Dramatic decrease in SIDS deaths, remarkably so. So we don't know exactly why kids get SIDS, but there seems to be something related to how they breathe and why they breathe, what's triggering them to breathe, which has led to some other recommendations that have come down the pike to help parents prevent SIDS. Now, I'll tell you, if you go back and you look at things like Dr. Spock's book, my grandmother was a nurse. She was amazing, actually. She was the kind of nurse, she was an OB nurse. She was the kind of OB nurse that basically said, honey, women have been having babies for thousands of years. Just bear down. Just do it. Have this child. And she lived by Dr. Spock. And Dr. Spock back in the day told you to swaddle your kid up and put your kid face down. Okay, that was what you were taught to do. Well, it turns out that's probably not the best thing to do. And there are several things you can do to decrease the risk of SIDS for new parents. So supine positioning is the first and most important, but also a firm sleeping surface. Not a squishy, pillow. Put them on a firm crib. And what you're not supposed to do is have anything in the crib with that baby. Anything. Not a stuffed animal, not a binky, not those little bumpers that are so cute that you get in your baby shower that are supposed to go inside the crib. Nope. Nothing is supposed to be in there with the baby. And in fact, when you put the baby to sleep, those little swaddler things, little Velcro swaddle, tuck it in, it's just like a little papoose. Put him in bed with that, done. That's how you're supposed to put your baby to bed. Breastfeeding seems to decrease the risk of SIDS. Getting the kids immunized decreases the risk of SIDS. And one of the other things that's crucial, and this may be SIDS and this may be suffocation, is not to sleep with your baby and not to have anybody sleep with your baby. So it's room sharing, not bed sharing. So getting the little bassinet that goes by the bedside so that you can pick the baby up, breastfeed, and then put the baby back in the thing that's right by the bedside, but not in bed with you. And I have personally seen 2 infants suffocated by sleeping in bed. One was with a parent, mom rolled over, suffocated her baby, woke up, she basically suffocated her baby. And the other was the 3-year-old, crawled in bed with the new baby and mom, and the 3-year-old slept on top of the baby, and that was that. So no bed sharing, okay, no bed sharing. And then the other thing that they think is probably the single most modifiable risk factor for newborns is smoking. So decreasing their risk to secondhand smoke. Highly recommended to sort of encourage new parents on this sort of thing, because God forbid you have a SIDS kid. It's just the most horrible thing. And for me, we have a peds ER. For us that work in the emergency department, the harder part for me is the SIDS thing is awful. It is so, I cannot imagine. 90% of marriages, after a child dies, 90% of marriages dissolve. Okay, 90%. Divorce rate is astronomically high. You already have this horrible SIDS thing that happened. And then my job as an emergency physician is to always remember it may not have been accidental. It may not have been SIDS. So there are certain things that you need to think about in a SIDS case. And I can't imagine these poor parents that are going through the worst possible thing that could ever happen in your life. And to have some highfalutin doctor questioning what happened. But it's our job. And it turns out that a very significant proportion of SIDS cases, when they do go for the full investigation, including autopsy, turn out not to be SIDS, turn out to be child abuse. So we need to pay attention. And there are certain things that warn you that this may not have been a SIDS case. So for instance, if the child had multiple ALTE episodes and now comes in as a SIDS, you gotta worry. If it's twins and they have simultaneous episodes, that doesn't happen. Okay, twins are twins. They're joined together genetically, but that doesn't happen. They don't do that. If there was a previous SIDS death in the family, you have to worry that it's not SIDS anymore, that it's actually potentially child abuse. And if there's anything funny on that baby, there's a little bit of blood around the nose, there's a little bit of blood around the mouth, which is suffocation. You can see that. Petechiae, you can see that. And you want to take a peek in those eye grounds and see if you see retinal hemorrhages. Those are all signs to you that this may not be a SIDS case, that this may actually be a child abuse case. And it's particularly important to do that to check all that stuff if there are other children at home. So it's really, it raises the stakes much, much higher. And if you have any worry, you call the Department of Child and Family Services on this. There are clearly certain situations where child abuse is more of a worry. And I think most of us are aware of this. Very young mothers, lower socioeconomic status, lower educational status, drug use, alcohol use, the unmarried mothers, particularly young mothers, are a particular problem. Postpartum depression, and very much so in developmentally or disabled children. So it is a disabled newborn. Or a newborn that has colic. Those are higher risk for it being not a SIDS death, but a child abuse death. And again, this is just our job to think about it and protect if there's any other children at home, because this one you can't protect anymore. It's done. And then do the appropriate sort of notification if needed. Yeah. Really problematic, actually. So it turns out that a lot of, I think honestly, all of them that get investigated when there's more than one SIDS, it's not SIDS. And there was actually a case recently of a woman who admitted to her 3 SIDS deaths kids, 40 years ago. She had actually killed, she was a nurse, and she admitted to having killed her kids. So multiple SIDS just don't really happen. Now, if you happen to be in a situation, I don't care if it's SIDS or not, if you have a child who dies in the ER, there's a really, really good paper in here on what you can do to help the family. It's abstract number 18. And there are a couple of things that I think are really, really useful to do. First, unless there is a reason legally you can't do it. So for instance, homicide kids, we can't do this in LA County right now, although we've fought this tremendously. But let the family hold their child as long as they want to. That turns out to be, for the family going through the worst thing on the planet, a very helpful thing to understand what happened and to let the child go. So that's crucial. Let them hold their baby, their child, as long as they need to. Second thing is, when if the child dies, they want to hear from the medical practitioner taking care of the patient. They don't want a social worker to tell them. They don't even want the nurse to tell them. If it's the NP the PA taking care, the physician taking care, they want to hear from the person who was directly taking care of their child. They want to hear from you. They do not want to witness your resuscitation. That's different from adults. Okay, if grandma comes in and she's dying, it turns out that family members, as long as it's done right, handle it better watching the resuscitation. If it's offered and they want to, they do better. Parents don't. Parents don't really want to know what you do to try to resuscitate their baby. So they don't want that. The other thing is they want a follow-up phone call from you in a day or two, just a touchstone. How you doing? You know, is there anything we can do to help you? Any questions we can answer for you? You know, anything we can do to help? And then finally, in the ER, offer them a memento. So cut a lock of the child's hair and put it in an envelope. Or better yet, we did this recently and it still makes me cry, call your L&D and have them bring down the ink and those little pieces of paper and put the handprints and the footprints on that little piece of paper and give it to the parents. It's something that at the time, it's an amazingly somber, profound thing to do, to offer. And it helps, I think, everybody, but it gives the parent something to have later. So how we do this is really important when a child dies. And there are some things that you can do that can help that I think doesn't take a lot of effort on your part that can be hugely important to the parents after all is said and done. So, I always need a hug after this. Okay, so, yeah, please. So that's a problem, actually. So when the O.J. Simpson case happened here in L.A. and Mark Furman and all the if it doesn't fit, you have to quit. LAPD went wacko, and the coroner went crazy about letting anybody anywhere near what might have been a murder victim because of maybe tampering of evidence and blah, blah, blah. They went nuts. We ended up at Harbor fighting back in a big way when it came to children that were murdered and children that died, coroner's case thing. So we actually have gotten to the point where it's okay to have a lock. They don't care about a lock of hair. And they actually don't care about footprints. They do care about holding a murder victim. So that is more of a problem. So we let them sit in the room, but with somebody in so they don't touch the victim in case it affects a murder investigation later. But this idea of they can't be, for a while they didn't want them even in the room or even to see anything. That's crazy. That's just crazy. So you have to not muck with evidence, but lock of hair won't change it at all. And then the footprints and thing, that it just depends on what the circumstances were. But I tend to do it as much as possible. Yeah, so that if it's a murder victim, no. And if it's a SIDS case, honestly, unless I'm sure it's abuse and not SIDS, oh my God, I let them hold their kid. If I'm really worried it's abuse, that's a different story. But I just can't imagine what that's like to go through. Yeah. You know, I haven't seen anybody look at the age per se. I think if it's a child, like truly a child, not your teenage, behemoth, football playing son, but it's truly a child. That seems to be the break point where it's your cuddly child rather than a soon-to-be adult or bigger person. So I think that's more the break point. Is it's the kid that you still would cuddle and watch TV with, where eventually your teenager says no. And I think that's probably the logical cutoff. But I haven't seen anybody say at this point. I think it's more of that psychological, my little munchkin versus. And there should be. I'm a huge proponent of that, having kind of gotten it into my practice and understanding what works and what doesn't. I think it's great. I think it's actually great to do that. And if you want to ask questions about it, we can talk about it on the last day here, because I think it's a wonderful practice. But it turns out for kids, and this is actually just one of many studies that say actually parents don't really want to see you do that to their little tiny person that they cuddle with. Okay.